I'm waiting for the message, waiting for the confirmation. Okay, perfect. So today we will take orthopedics and just few important questions which are frequently asked in one or other manner. So one of the question is about like patient is having a fall on ground, and that is typically fall on outstretched hand, right? So whenever you have this kind of word, in short we usually write it foosh injury. So foosh is the mechanism of injury for majority of upper limb fractures, and classically in this case if you look at the x-ray, I think most of you can just mark it out that it is the classical fracture of clavicle, right? So this is a fracture of clavicle, and so if we just about like this is medial 2/3 and this is the lateral 1/3. So classically the junction is the medial 2/3 and lateral 1/3, and treatment is pretty simple. We have to simply majority of the cases can be managed conservatively, and we can simply give a figure of 8 bandage, right? So we can give a figure of 8 bandage. So nothing much has to be done. Majority of the cases they heal very nicely, although there might be some amount of malunion, but that is of no functional concern, because I think if you must be knowing that the function of the clavicle is to transmit the weight of upper limb to the trunk. So this is the usual treatment. Very rarely if there is any neurovascular injury, then we can think of going for open reduction internal fixation with plate. Otherwise for majority of the cases simply we have to give a figure of 8 brace. Then the second question is about from a very important topic, that is dislocation of shoulder. So here a patient is having recurrent dislocation, and when the doctor tries to abduct his arm and extend the elbow with external rotation. Now this is very important. The patient became very apprehensive and he is not allowing the doctor to complete the test. Now if you look at the picture, here you can see the upper limb is abducted and it is externally rotated. So the moment there is this kind of movement, abduction and external rotation, that is one maneuver which can lead to anterior dislocation of shoulder. So particularly in cases of recurrent anterior shoulder dislocation, the moment there is abduction and external rotation, the patient will realize that now my shoulder joint is going to be dislocated, so he will become very apprehensive and he will not allow the doctor to complete the test, right? So this is apprehension test or apprehension sign, very suggestive of recurrent anterior shoulder dislocation. Then the next question is about is an image based question, and this is about a tumor. So whenever you have image based questions regarding the tumor, the very first thing you have to look at the site or the location in the bone. So whether it is in the epiphysis, whether it is in the metaphysis, or it is in the diphysis. And there are at least 3 tumors which everyone should know. Like if it is epiphysis, you should think of giant cell tumor. If it is in metaphysis, think of osteosarcoma. And if it is in diphysis, think of Ewing sarcoma, right? So here we can see that this is the epiphyseal region. So here we can see a tumor which is more towards lateral side. So it is eccentric. So eccentric epiphyseal tumor, always think of giant cell tumor. So this is a classical giant cell tumor location. And yes, if we talk about the radiological feature, you can see the classical soap bubble appearance, something like this. So that is the soap bubble appearance, right? So very easy to identify a giant cell tumor. Then moving forward to next question, a patient was on long-term steroid therapy and now is complaining of pain in both the hip joints. So here if somebody is on the steroid therapy for a long term, then there is possibility of the development of avascular necrosis of the femoral head, right? And that clinically presents as the pain in the hip joint. And here, if you look at the X-ray, on either side, we can see that the smooth rounded appearance of the femoral head is lost. So this is one important clue to the development of avascular necrosis. And secondly, you can see there are areas of more density which is known as osteosclerosis. So the classical finding will be, if you look at the rounded contour of the femoral head is lost, right? So this is classically suggestive of avascular necrosis, right? So usually when we teach students about avascular necrosis, we always discuss in terms of fractures, like fracture through the neck of femur can result in avascular necrosis of the femoral head. But this is a non-traumatic cause of avascular necrosis of femoral head, where there is a history of prolonged steroid intake, right? So this is AVN. Then moving forward, a patient was having a tumor in the shin, and classically the pain which used to come, it used to get relieved by taking aspirin, and the CT scan is shown below. Now here, one important thing is that the NSAID, especially the aspirin, is very useful in relieving the pain, and therefore this particular tumor is also known as aspirin tumor, right? So that's why this particular tumor is known as aspirin tumor, and otherwise this tumor is known as osteoid osteoma. Clear? So this is osteoid osteoma, which is the most common primary benign bony tumor, and classically it is found in the leg region, especially involving the tibia. And in the given CT scan, we can see the transverse section, and this is the fibula, and this is the tibia, right? And in on one side, in the cortex of the tibia, we can see a nidus, right? So here we can see a nidus, and this is usually less than 1 centimeter in size, and it's present in the cortex, and it is surrounded by sclerotic bone. So this is a classical appearance of osteoid osteoma, right, which is the most common primary benign bony tumor, right? So most common primary benign bony tumor. Clear? So osteoid osteoma, and the classical presentation is the moment the patient takes aspirin, the pain is relieved, and that's why it is known as aspirin tumor. So we can see the tumor in the cortex, and classically the lesion is described as a nidus. Then next question, fracture is shown in the image in the X-ray, and it is specifically mentioned that this kind of fracture does not require any specific treatment. So here we can see there is a fracture through the scapula, and since the scapula is surrounded by muscles all around, so any operative intervention is usually not needed. Just a cuff and collar sling for 2 to 3 weeks is sufficient. So we don't bother too much about managing fractures of scapula. Then now this is very important topic, and every year and almost in every exam, whether it is FMGE, NEET, PG, we have a question from this segment. And here there is a classical history of road traffic accident, and after that the clinical picture is shown here. And what we can see here in the picture. Now for this, to understand this, you should draw a line from the middle, or you can say a midline. So what we can see on both the sides, the lower limbs are abducted, right? So one of the deformity is abduction. Clear? So one is abduction, and then secondly, what we can see that there is external rotation of both the lower limbs, and that is evident by the fact that the lateral border of the foot is touching the couch. So another deformity is external rotation, and obviously there is some degree of flexion at the hip joint. So you will write flexion. So taking these three terms together, flexion, abduction, external rotation, it comes out to be a Faber deformity. And Faber deformity post trauma, you can say that this is a case of anterior hip dislocation. And obviously in this case it is bilateral. So this is how you will identify anterior hip dislocation, right? And classically the mnemonic is Faber. Yes, Himalayan, absolutely right, this is Faber. And in majority of the exams, actually we have a question from posterior hip dislocation that presents as Fadir, right? So I have kept Faber first. Then again there is a history of RTA. Now X-ray is shown below. Now you have to identify what injury is being shown on the X-ray. Now here obviously we can see this is the acetabulum, right? And this one is the head of femur. So we can say that the head of femur has moved out of the acetabular cavity. So one thing is that it is a case of hip dislocation. Yes, Himalayan, Fadir is posterior dislocation. Flexion, adduction, internal rotation, right? Fadir. Okay. Now this is a case of hip dislocation. Now we have to identify this is what type of dislocation, anterior or posterior. And let us just summarize the mnemonics like what we discussed now. Faber is anterior hip dislocation, and the other one, Fadir, is the posterior dislocation. So flexion, adduction, internal rotation, right? Now how we can identify on X-ray that whether there is adduction or abduction, or whether there is external rotation or internal rotation. So again you need to draw a line from the middle of the body, and we can see that the affected lower limb is adducted, right? So we can see that this is coming towards the midline, so this is adducted, right? So this is adducted. One thing we can just mark it out. Now second thing, although just getting this particular word here, we can be sure that yes, it is going to be posterior hip dislocation, because adduction is the component of posterior hip dislocation, whereas abduction is the component of anterior hip dislocation. Now I just want to tell you how we can mark out internal rotation as well on the X-ray. Now for that you need to locate the lesser trochanter. This is the normal side. So on the normal side we can see the lesser trochanter, but on the affected side it is very difficult to mark out the lesser trochanter. Now this is very difficult because there is internal rotation. So the lesser trochanter has moved behind the shaft of femur, right? So this is how we can say that there is internal rotation. Clear? So we can just say that there is adduction, there is internal rotation, obviously there will be flexion, so that will come out to be Fadir, and therefore this is a case of posterior hip dislocation. So this is how we identify whether a given X-ray is anterior hip dislocation or a posterior hip dislocation. Similarly, simply you have to just see whether the limb is adducted or abducted, and if you can just mark it out, you can get your answer, right? Then next question is about nerve injuries, and here in fractures of humerus, we know that majority of Himalayan, yes, hip is the most common, the posterior one is the most common for hip, and for shoulder it is anterior, right? Okay, so if we just most common types, if we just write it over here, yes, for hip it is posterior, and for shoulder it is anterior. Clear? So yes, you can just remember it like that. So these are the most common types. Okay. Now moving forward to the nerves which can be injured in cases of fractures humerus. So again, for this you need to know the anatomy of humerus in relation to the nerves, and the common one which are very frequently asked, one is of course the radial nerve which passes through the spiral groove. Clear? So whenever there is fracture of shaft of humerus, radial nerve can be injured. Ulnar nerve passes behind the medial epicondyle. So if there is any fracture of the medial epicondyle, there is possibility of injury to median nerve, ulnar nerve, pardon. And axillary nerve is located around the surgical neck of humerus. So whenever there is fracture of surgical neck of humerus, there is possibility of injury to axillary nerve. So these are the three important nerves which are very frequently asked, and one should be very well versed with them. And posterior interosseous nerve has nothing to do with humerus. It is of course related to the head and the neck of radius. So it is related to the head neck region of radius. Clear? So it is not related to humerus. So this kind of question is usually based on the anatomy. So if you know the anatomical landmarks, I think you can never be wrong. And yes, no need to run after the entire anatomy, just take the ones based on which the questions are asked frequently, right? Then this is how we can just locate the nerves. So this one is the axillary nerve here around the surgical neck of humerus. Then we can see the radial nerve crossing from the medial to the lateral side posteriorly through the spiral groove, and the ulnar nerve passing behind the medial epicondyle. You can see here, this is surgical neck, and the radial nerve passing through the spiral groove, and that's why it is also known as the radial groove. So just three nerves you need to remember. And yes, median nerve can be injured in fracture supracondylar region of humerus, right? So fracture supracondylar humerus. So these are the four importantly injured nerves, and although it is anterior interosseous nerve branch which is commonly injured, but you can take median nerve as the parent nerve as well. So this much you need to remember. Then moving forward, a 3-year-old child had a history of fall, and at that time X-ray was absolutely normal, but later on the child presented with a deformity as shown below. Now what can be the cause here? Now what happens if you look here, there is calcaneo valgus kind of deformity, right? So this is calcaneo valgus. Now what happens, to understand this you need to know the radiological anatomy, and I think most of you must be knowing that this is the physis, which is also known as the growth plate. Now sometimes what happens whenever there is a injury, now what can happen, suppose if there is injury towards this side, so this side of physis will be injured and it will not contribute to the increase in the length of the bone, but the normal side will continue to increase in length, and therefore there will be a deformity which will be something like this. So this is the calcaneo valgus deformity. So if there is a child which is coming to you with deformity and giving you a past history of over that particular area which was not diagnosed on X-ray, of course it is not easy to diagnose compression of the growth plate sort of injuries on X-ray. So we can presume that it might be some epiphyseal injury or growth plate injury that was missed at the time of injury, and now it has resulted in growth imbalance, right? So this is very very important from pediatric injuries. Then next question, an obese woman has presented with pain in both the knee joints, right? And one can see the one can hear the sounds or click whenever she is walking, and whenever she is going up and down over the stairs she had more pain, and X-ray is given. Now what can be the diagnosis? Now this is a classical case which we see in clinical practice, especially in obese elderly women presenting with pain in both the knee joints. So this is a classical case of osteoarthritis of knee joint, which is the pain is usually aggravated by going upstairs or coming downstairs or using Indian type of commode, so or sitting, squatting position, cross-legged position. So all these activities they use to increase the pain, right? And if we look at the X-ray, what we can see here, if we see, you can see a genu varus kind of deformity, right? So the leg is coming inside, so this is genu varum deformity or varus deformity on both the sides, right? And apart from this, what else you can see, like look at the knee joint proper, and in the knee joint we can see there is opening of the lateral compartment, right? So this is the lateral compartment opening, and there is narrowing of the medial compartment. Similarly, you can see almost the condyles of the medial condyles of the femur and the tibia, they are almost touching each other, and on the lateral side there is slight opening up, right? So this is classically indicative of varus deformity, and reduction in joint space, especially in elderly, affecting knee joints. Straight away you can take it, you can label it as a case of osteoarthritis, right? So very easy to identify and very common in clinical practice as well. So this is how you need to identify osteoarthritis, and in Indian population it is very common. So in Indian population it is usually affecting the knee, whereas if we talk about the Western population, it usually affects the hip joint. Clear? So osteoarthritis. Then moving forward, elderly patient underwent THR, that is total hip replacement, and this was done for osteoarthritis of hip joint, but later on she developed breathlessness. Now, one of the complications with long duration surgeries, especially in elderly, is the possibility of DVT, which can lead to pulmonary thromboembolism, right? So this deep venous thrombosis is one of the, yes, Himalayan, it is thromboembolism, and this is because of deep venous thrombosis. So for deep venous thrombosis, two important points from orthopedics point of view. One is, of course, the age. So elderly patient, they are more prone to develop DVT. Then secondly, long duration surgeries, like here in this case we can see THR, and another one is prolonged bedridden state, right? So if the patient is bedridden for long period of time, he is predisposed to develop DVT. And from this deep venous thrombosis, there might be release of emboli, which can go, and this can produce respiratory symptoms. And therefore, whenever we are doing THR, we always give low molecular weight heparin as a prophylactic measure, because we don't want to land up in this complication, right? So age, elderly person, long duration surgery, prolonged bedridden state, at very risk of developing deep venous thrombosis, right? So this is how you can solve this question. The next question, a person who is taking non-vegetarian food and is now presenting with this kind of scenario, and now what we can see here, this is the great toe, right? This is first metatarsal, and this is somewhere the area of metatarsophalangeal joint. And here what we can see classically, we can see swelling, we can see redness. So there is swelling, there is redness, and I think this is very characteristic or very unique. The moment you see inflammatory signs at the region of first metatarsophalangeal joint or the area around the great toe, straight away you can jump and you can make a diagnosis of gout, right? Straight away. It's a classical presentation, and I think most of you must be knowing that what is gout. Gout is hyperuricemia. So in the blood, the level of uric acid is raised. So this is hyperuricemia, and this is predisposed by persons who are taking red meat, right? So here, and this is also documented as uric acid is 10. Normally it should be around 6.5, but here it is 10, so it is an indicator that yes, uric acid value is high. Now what we want to do, we have to reduce the formation of uric acid, and therefore we will give one drug which will inhibit one enzyme which is involved in the pathway of uric acid synthesis, right? So I think a little bit of biochemistry here. Yes, through these you are absolutely right. This is gout. So that enzyme is xanthine oxidase, right? So yes, Himalayan, you are right. Here we can do one thing. Now here, what if you look at a classical word, similar episodes, right? So this means this is a case of chronic gout, right? So in chronic gout we have to give allopurinol, which is inhibitor of xanthine oxidase. And suppose if this patient was having first episode, then it is acute, and for acute, Himalayan, you are absolutely right, we can give NSAIDs, right? So for first episode or acute gout, we can give NSAIDs, but if it is recurring again and again, then we need to give allopurinol. So allopurinol, if you say, it is the drug of choice for chronic gout. Clear? So if there are recurrent episodes, then we can give allopurinol, which will inhibit xanthine oxidase, and therefore there will be less production of uric acid. Clear? So this is a little bit of, biochemistry integrated, pharmacology integrated orthopedic case. Classical gout. Then next question. Now this is a little bit about pure theory about problem related to fracture union. Now here the question is about like a fracture is uniting in a wrong position. So whenever a fracture unites in a wrong position, for wrong we use the word mal. Clear? And for union, simply you can write malunion. So if the fracture unite in a wrong position, it is malunion. Mal means actually bad, right? So very good, Himalayan, it is malunion. And I have just taken the opportunity to discuss two more types, two more related terms. If the fracture is taking little longer time than what is usually expected for union, now it is taking longer time, so it means the process is delayed. Clear? So you will write delayed, and of course you will write union. So taking more time, delayed union. Now if it fails to unite, means it is not uniting anymore, so simply you will write it is non-union, right? So most of the time the explanation itself speaks for the answer. So taking more time, delayed union, not uniting at all, non-union, united but in wrong position, malunion. Clear? Now then moving forward to one surgical principle, that is destructive forces are converted into compressive forces. Now what is this principle and where it is used? Now usually what happens, suppose here we are seeing a case of fracture olecranon, right? So this is a fracture olecranon, and this is triceps muscle which is attached to the olecranon process. So if you don't fix the fracture, the triceps muscle will pull the proximal fragment every time the patient will flex the elbow. So what we do a tension band wiring, and by this operative procedure, what will happen, the moment patient flexes the elbow and the moment the triceps tries to take away the proximal fragment, it will indirectly bring the fragments closure. So moving the fragments moving away is known as distraction. The fragments coming closure is known as compression. And for a fracture we always favor compression because that will promote the union. So tension band wiring is a surgical principle which employs the concept of distraction forces being converted into compression forces. And for tension band wiring, from exam point of view, just remember two examples. One is fracture olecranon and another is fracture patella. So these are two fractures where we commonly do tension band wiring, right? Then moving forward, A elderly post-menopausal lady had a history of fall in bathroom. Again, this is fouche injury, that is outstretched hand. And then she had a fracture around the wrist, most likely type of fracture. Now here in this x-ray, we can mark out the fracture, and even if there is no x-ray, looking with the case history, we can directly go and we can say that this must be a case of fracture Colles, right? So very common in clinical practice, elderly people having a fall on outstretched hand and landing up in fracture of distal radius at the corticocancellous junction. So if we see here, this is the distal fragment, right? So this one is the distal fragment, and this one is the proximal fragment here. So this is proximal and this is distal, and we can see that the distal fragment has gone dorsally because this is dorsum, right? So classical displacement for fracture Colles. Clear? So this much history, straight away you can answer fracture Colles. Then dashboard injury. This is a very common question, one of the questions from this topic we have already taken, and this is nothing except posterior dislocation of hip, and this is the mechanism. Actually, whenever there is accident and the car suddenly stops, the knee strikes the dashboard and there is backward pressure which is transmitted along the shaft of femur, and that pulls out the head of femur from the acetabulum. So it leads to posterior hip dislocation. Clear? So this is posterior hip dislocation, dashboard injury. Okay, and if posterior hip dislocation is not there in the options, then you can mark knee injury as well. But yes, from exam point of view, most of the time the answer is posterior hip dislocation. Then tuberculosis of hip is again very important, and most of the time we have a question from the different stages. What is the appearance of the lower limb, and what pathology will lead to what kind of appearance. So here if we see, the question is about the synovitis stage of TB hip. Now in synovitis stage, which is usually the the stage 1 of the TB hip. Now what happens whenever there is synovitis? Obviously the synovium is inflamed and this will produce more of synovial fluid, right? So this will produce more of synovial fluid, and now when this synovial fluid will be within the capsule of the hip joint, capsule will try to assume one position in which it can accommodate a maximum amount of synovial fluid. So here there is synovitis, of course, leading to increased production of synovial fluid, and that position is actually Faber, right? So this is Faber, that is flexion, abduction, external rotation of the hip joint. That is the position in which the hip joint has maximum capacity, right? And if we look at a person with Faber deformity, we will feel as if the limb is longer as compared to other limb, but in reality the limbs of the length of both limbs are equal in reality, but it appears lengthier, so it is known as apparent lengthening. Clear? So from a distance we feel as if it is lengthened, but in reality the length is same, so it is apparent lengthening, and both the lower limbs have equal length, right? Now if at this stage the condition is not checked, it will go into stage 2, that is early arthritis. Now the condition will involve the hip joint proper. There is involvement of the articular surfaces. Now what will happen? Because of this inflammation, the surrounding muscles will go into a state of spasm, and we know that in the hip joint there are different group of muscles. So the powerful muscles will overact and they will pull the lower limb in their direction of action, right? So the muscles which are powerful here are the flexors, adductors and internal rotators. So the limb will go into flexion, adduction and internal rotation. But again, when we measure the length, so it will be equal to other side. So the the limb length is equal to other side, the normal side. But yes, when the limb is in this attitude, it looks shorter than the other side. So this is known as apparent shortening. Clear? So this is known as apparent shortening, because we can feel as if the limb is shorter because of added deformity, but when we actually measure both the lower limbs, the length comes out to be same. So this is stage 1 and stage 2. And then comes the stage 3. Now what happens in stage 3? And after early arthritis, obviously the pathology will keep on going and patient will go into advanced arthritis, right? So here now there is actual bony damage. So what will happen? The affected limb will be smaller or shorter than the normal limb. So affected limb will be shorter than the normal lower limb, right? So this is how we will have the description about the different stages of TB hip. And here the position will continue to be same what was in stage 2, and that was flexion, adduction and internal rotation. Clear? But since there is actual destruction of the bone, so we will get a true shortening. Right? So this is how you need to summarize, or you need to remember the stages of TB hip, and which is again a very important segment from which we have the questions. So in this question the word is true shortening. So straight away you can go to the answer, that is yes, it is a stage 3, that is advanced arthritis, in which there is real damage to the bone, and therefore the length will also shorten accordingly. Then next question is about one maneuver which has been shown here, and we can see the examiner is pressing upon the lateral epicondyle area, and the movement which is being tested here is the patient is told to do dorsiflexion, and the doctor is resisting it. So what happens when the patient tries to do the dorsiflexion against resistance? There is some strain over the lateral epicondyle, and from anatomy I think all of you must be knowing that it is common extensor origin, right? So this particular condition is known as lateral epicondylitis, right? Or in clinical practice we call it tennis elbow, right? So this is lateral epicondylitis, clear, or tennis elbow. And this particular test which is being done here is known as Colles test, clear? So this is Colles test. So we just want to put the extensors of the wrist under stress, and that will produce pain at the lateral epicondyle area. So Colles test for tennis elbow or lateral epicondylitis. Now X-ray is given, and we have to find out what actually is being shown here. So now we can see that two lines are being drawn on either side, and what actually we need to mark out is we need to mark out the area of the femoral head epiphysis, right? So this is on the one side and this is on the other side. Now here what we can see on this side, the line is passing above the level of the femoral head epiphysis, right? So this is femoral head epiphysis, or epiphysis of Himalayan. Yes, this is tennis elbow. Yes, right. So here we can see that the line which is drawn along the lateral part of neck of femur is passing above the head, the femoral head epiphysis, but on one side it is passing through the substance. So this is actually normal. This should be the normal scenario. It should pass through the substance of the femoral head epiphysis, but here it is not passing. It means this has slipped down. So this condition is known as slipped capital. Now capital word is for head, Clear? And head of which? Femur. So we will write femoral. And since it is a child, so we will write epiphysis. Clear? So this condition is known as slipped capital femoral epiphysis, and this radiological sign is known as Tretovan sign. Right? So this is classical Tretovan sign, and here when we draw a line along the upper part of the neck of femur, it should normally pass through the femoral head epiphysis, but if there is any slipping, which usually happens downward, the line will pass above the femoral head epiphysis. So this is Tretovan sign, classical of slipped capital femoral epiphysis. Now next question, there is a 5-year-old child with knee pain, irritability, and most importantly gum bleeding. Now the moment you have this word gum bleeding, I think most of you can answer that this is what? This is nothing except scurvy, because there is only one classical condition which presents with gum bleeding. And when we look at the X-ray, we can see few important signs. One is Pelkan spur. So P is Pelkan spur. Clear? Then T is Trümmerfeld zone. Right? So this is Trümmerfeld zone. And F is white line of Frankel. So these are few important radiological features in scurvy, right? So Pelkan spur, white line of Frankel, Wimberger ring sign is also seen in epiphysis, and the classical clue is gum bleeding. Then moving forward, in vitamin D deficiency rickets, what values you will see? Yes, there will be, since it is vitamin D deficiency, so there will be low vitamin D. This will lead to low serum calcium, and there will be a high parathormone. So this is the equation which we see in vitamin D deficiency rickets: low serum vitamin D, low serum calcium, and high parathormone. Clear? Next question. An alcoholic patient slept with keeping her head over the arm, and next morning when he woke up, he found that his radial nerve was paralyzed. Now what is this? Now here, yes, Himalayan, absolutely right. This is Saturday night palsy. So whenever somebody, either keeps his head over the arm, or if a highly intoxicated fellow sleeps on a chair, the arm resting against the armrest, again there can be compression of the radial nerve, and the fellow will develop nerve palsy, which is actually neuropraxia. Right, so this is actually neuropraxia. And talking in terms of nerve injury, we have 3 varieties. Of course, this one which we're discussing here is neuropraxia. And now here, anatomy is normal. It means the nerve is not cut. There is no damage to axon or the structure of the nerve. But yes, there is physiology is gone. Now, anatomy is normal, so we can expect 100% recovery. So prognosis of neuropraxia is very good. We can expect 100% recovery. The other variety is axonaut masses. Right? So other variety is axonaut masses, and here the axon is cut. So there is injury. Yes, of course, axon is cut. And so if we write here like this, axon is cut, physiology will, yes, it will go. So here it is, you can say 50-50. Recovery can occur, recovery may not occur. And the third variety is neurot masses. Now in neurot masses, the entire nerve is cut. Clear? So you can say it is 2-part injury, 2-part cut. Physiology will go, and here the chance is 0%, unless and until you do some intervention in the form of nerve repair or any other intervention, right? So these are the different types of injury, and in majority of the cases, if there is no cut injury, it is usually a neuropraxia and it carries a good prognosis. We can assure the patient that yes, your nerve will start functioning over a certain period of time. So this is neuropraxia and 100% recovery because the anatomy is okay. Now next question is about a lady having tingling sensation in the thumb, index finger, and the middle finger, right? So now this is aggravated by palmar flexing the wrist for 1 minute. So if you look at the classical, especially on the volar aspect, if we see this is, we can say this is 3.5. So volar 3.5, this is all territory of median nerve. Clear? Because medial 1.5 is all territory of ulnar nerve. So this is lateral. Clear? If we write medial 1.5, this is all territory of ulnar nerve. On volar aspect, this is very important, right? So what happens, if there is any compression of median nerve, patient will have paresthesia in the distribution of the median nerve, that is lateral 3.5. So thumb, index finger, and middle finger, and some part of ring finger as well. And this is aggravated if we do palmar flexion, that is actually the Phelan test. So we are aggravating the compression. So obviously the symptoms will also be aggravated. So this is the Phelan test. So this is a classical presentation of carpal tunnel syndrome. So the moment you find any word related to sensory disturbances in the region of thumb, index finger, or middle finger, straight away you can jump to median nerve compression at wrist, and that is usually the carpal tunnel syndrome. So this is how we can understand the anatomy of median nerve. So this is 1, 2, 3, and this is half. And counting from medial side, this is 1 and this is half. So medial 1.5 ulnar nerve, and radial 3.5 median nerve. Clear? And this is of course volar aspect. So this is how you can remember carpal tunnel syndrome. Again, a very important entity from exam point of view, and also from clinical point of view. So that's enough for orthopedic session. I am planning to take all the subjects, and I hope you must have enjoyed the session. And if there is any feedback, let me know. All these PDFs you will find on my app, and very shortly I'll be coming back with anatomy. So stay tuned. Dev, pranam, bache pranam. So thank everyone, Himalayan, Shruti, Dev, Kakul, thanks everyone. Very shortly I'll come up with another subject, and I'll drop the link in Telegram or WhatsApp. See you. Keep studying. Bye bye.